Hello and welcome to Inside Exercise. I'm Emeritus Professor Glenn McConell from Victoria University in Australia, and I'm also currently a Danish Diabetes and Endocrine Academy visiting professor at the University of Copenhagen in Denmark. The idea behind Inside Exercise is to bring to you the absolute who's who of exercise research, so exercise physiology, exercise metabolism, and exercise and health. And what I'm really wanting is for you to get your exercise information from the research experts rather than from influencers. And indeed, today I bring to you Professor Michael Kjær from the Department of Clinical Medicine at Bispebjerg Hospital in Copenhagen, who's also associated with the University of Copenhagen in Denmark. He has a really stellar and varied background. He's a medical doctor who started off looking at glucose metabolism during exercise, specifically what regulates liver glucose output during exercise. He then moved into muscle, and now is a world authority on tendons. So the effect of exercise on tendons, what causes tendon injury, whether you could prevent and treat tendon injuries, so whether it's best to rest the tendon when it's injured or exercise it, and we'll see that it's actually better to exercise it, and whether any sort of nutritional or drug treatments can improve tendon injuries. I found it really interesting. I think you will too, so stick around. I would, of course, prefer you to watch the whole chat, and that way you'll get the full context. But if you'd like to jump around a little bit, you can look down the notes, and then you'll see timestamps there. So on YouTube, you can go to the time, which is in blue, click on it, and it will move to that section. And on the other platforms, you can just go down, you can see the times, and you can move to them manually. And if you can do me a favor, if you could like, subscribe, leave comments, etc., that'll help get the message out, because when people do searches, the algorithm will tend to suggest Inside Exercise more if there's more likes, subscribes, comments, etc. Okay, so enjoy the chat. Hi, Michael. How are you? Welcome to Inside Exercise. Thanks for coming on.
Thank you very much. I'm fine. How are you?
Yeah, I'm good. So why don't you just explain? So you're a medical doctor who's also doing exercise research. So quite often, I'm asking people, were you a sports person first or a researcher first or whatever, but you're actually a medical person. So how did you actually get into this? Were you sort of interested in exercise and sport and then thought, I want to be a sports medicine doctor, or did you do medicine, or how did you end up doing what you did?
I knew very early that I was very interested in exercise. So I've been doing exercise my whole childhood and adolescent period. And when I had to decide what to study, I was actually dividing between studying exercise science or medicine. And I chose medicine simply because I thought maybe there are some more options and I could still use the interest of exercise. But I knew from the first day of medical school that wherever I would end up, then it would be something with exercise. And that was really what made me thrill. If I had become a psychiatrist, I'd probably have done training in psychiatric patients. So at that time, it was the exercise definitely first. And then the choice of occupation came after that. And as you probably know, I ended up then specializing in rheumatology, because that was sort of close to sports medicine. And we don't have sort of a big medical specialty called sports medicine in Denmark, despite the fact that I'm professor of sports medicine. But that was the entrance of it, yeah.
But do you still not have because in Australia we have sports medicine specialty. Is there still no sports medicine specialty in Denmark?
No, there's not. I mean, basically in Denmark, so that rheumatology covers also physical rehabilitation, and therefore they sort of feel that sports medicine is on the non-surgical field. That's the area. And then, of course, if you're a surgeon, you're an orthopedic surgeon, and so that's the way it is. And so it also, that's also why it started with during medical school, that I was very interested in beginning to go into some kind of research. And there, because I was active myself, but I was also coaching on a high level European handball. And then at a course there, one of the sort of top level courses there, I had Bengt Saltin as a teacher. And I heard about Bengt Saltin, and he was not at the medical school, though he's medically educated, but he was at the natural science faculty. And I asked him whether I could come and do some research, because I was interested and curious about how the body is functioning. I didn't study medicine necessarily to sort of save mankind. I studied actually to find out how things are going on in the human body. And he was very open. but he said to me at that time, which was quite interesting, maybe it was because he was generous, or maybe it was because he didn't bother having me. He said, but you're from the medical school. And then he said, you should go to one of his colleagues, a professor there who's called Henrik Galbo, who's now retired, because as Bengt Saltin said, he's the only one at the medical faculty who knows anything about medicine, or about exercise in medicine. And then I went over and knocked on the door and said, I would like to start doing some research. And Henrik Galbo looked at me and said, how far are you in the medical studies? And I said, I'm 2 years into medical studies. And then he said, then you haven't even finished your physiology course. I said, no, because that's on the 3rd year. And then he said, you can call me back when you've passed that exam. And then I called him a year later, and then he said, oh, we better find something for you to do. So then he was my main supervisor during my PhD, with Bengt Saltin as the co-supervisor at that time. So it all sort of has come together there. And the rest is history, because then I stayed there doing research.
That's an interesting background. So did you even know that Bengt Saltin was a big name at that time, or in exercise?
Oh yeah, I did. I mean, in fact, I actually had during the 3rd year of medical school, I actually was able to buy one of the books about the first biochemistry and exercise meetings, and had looked into that. And I knew Bengt Saltin was very much at that time very much into the descriptive phases of a lot of exercises. And then, of course, when I joined Henrik Galbo's lab, I obviously went into the more metabolism and hormonal fields. So that was my well, in Denmark it's the Doctor of Medical Science, but it would be like a PhD program for 3 years, where I then studied primarily the sympathetic nervous system, adrenaline, noradrenaline, and what was going on during exercise, how much was regulated from the brain, how much from the muscle. And also, of course, spent a lot of years looking at the liver glucose production, what is really regulating the blood sugar during exercise. So those were sort of two years at the medical faculty here for research department of physiology, and then I spent a year as a postdoc at Stanford, where I then got in touch with Gerald Reaven, who's now unfortunately dead, but he was sort of the father of syndrome X and metabolic syndrome, and there we got to do some exercise studies on type 2 diabetics. And then after I came back, and then I sort of took my own track there.
That's how I knew you. So during my PhD in 1991 and 1995, there's all these papers. I was doing glucose metabolism, so there's all these papers. Obviously, Galbo, Henrik Galbo, and then Eric Richter, who I had on 4 or 5 podcasts ago, who was also studying with Galbo, and then your stuff. And I couldn't believe and it's funny, I'm here in Copenhagen doing invasive studies with Eric Richter now myself, but I couldn't believe the stuff you did with the liver, your epidurals and epidural, and then electrically stimulating the leg muscles to contract to then see. Why don't you just tell us a quick? Yeah.
And blocking the celiac ganglion was also very sort of challenging to do. But that's right. We were trying to find out whether there was the brain or the muscle that was really in control. And the quick answer at the end was that they're both important. And depending on which hormones you're looking at, it was either the signals from the muscle or the central effort. And it basically comes back to the old story that August Krogh and Linhart started with the regulation of both the circulation and heart rate and ventilation. So it's funny, there is a parallel there. So.
Well, I actually quote, I don't know, hopefully I'm quoting it properly, but I quite often say how there's a lot of redundancy. So something that's so important as glucose release from the liver, there's redundancy. So if you knock the muscles out, so there's no feedback, you still have some glucose uptake. If you knock the signal from the brain, you still get glucose output. And it's this similar thing with breathing. So you just said heart rate and breathing. You try and look at regulation of breathing, and it's like it's so important that something else will kick in.
No, I think you're totally right. I think it's respiration physiologist Julius Comroe. He wrote in one of the book, The Retrospectoscope, where he says that if there is an important thing to be taken care of in the human body, there's probably more than one way to do it. And that was exactly what we found out, because there were all these nice animal studies, also from Erik Richter and others, which showed that if you manipulated a certain thing, you could alter the glucose production. But in humans, whether we took the nerves away by studying people who were liver transplanted, or we did other acute changes, we could still not get to the core of it. And after many years of studies there, actually one of the last studies in that regards that I did together with David Wasserman from the US, that was actually showing that it is the ratio between glucagon and insulin that probably is a very important factor for the release of sugar from the liver. But that's how it is sometimes. We were not able to pick out sort of a magic factor that was really the one that nailed it. But we were able, I think, to manipulate human models as much as we could, at least. So
well, that's a good advertisement for my podcast as well, because I've had David Wasserman on the podcast. And that was interesting as well, because for a while there, they'd say the glucagon didn't really change much during exercise, but it's because that was just the systemic. If you looked at the the portal vein, you see it did, etc. So,
no,
but yeah,
that's a good point. And we met up because he was studying a lot in dogs, and we were doing it in humans. And then we had a common postdoc who then joined the lab here, and we did a study together. So that's
Yeah, and the redundancy thing is similar again with Erik Richter, because I was in the corridor the other day, Erik Richter, Jan Motoczewski, and myself, and Jan's been on the podcast as well, Jorgen. And we're saying how if you look at regulation of glucose uptake in the muscle, so in the mouse studies, you look at knockout AMPK and they still have normal glucose uptake pretty much. I've done nitric oxide and knocked out nNOS and they still have normal glucose uptake. And then the studies showing you knock out CAM kinase, so it's like there's just all this redundancy. So it makes it hard to study.
Yeah, that's a very good point, and for many years you can say that this has been a big discussion in also in relation to publication. And I mean, I don't, no offense, but it's really difficult to get invasive human studies really published well, because you can always argue in the humans that you have not knocked out it totally, and a lot of the knockout things in humans would probably cause death in people if you did it. But in animals you can very often have a cleaner model. But the question is whether it really means something for human. And well, it's very, very elegant that you can in different models show the importance of a certain factor, and that can be sort of a proof that it has an important role. I think it's hypothesis creating and not necessarily solving the question, because a lot of studies, even studies which are published very, very well from cellular or molecular or animal work, cannot be reproduced in humans. In fact, there are studies where they tried in humans and they avoid putting it into the publication because that will deduct from the news of the publication. Because it's actually, it is nice to know, but it hasn't got a real importance for human body.
Yeah, that's why I think it's important to sort of try and look at both. It's a bit hard, but I've been doing it. Erik does it. You do your human studies as much as you can. We had one study, we had 7 catheters in each person, femoral artery, femoral vein, both legs, infusing microbubbles and looking at contrast enhanced ultrasound for muscle blood flow and insulin and glucose. But then you do your knockout. You think, I think it's this enzyme, and so then you knock it out. But anyway, so this is very interesting. So that's how I got to know your work initially. And so you've gone from liver. And then why don't you tell us how you moved, you were talking about muscle there, and then into tendon.
Yeah, then it moved. I mean, the quick answer is then it moved a little bit from this liver glucose production, because then we wanted to find a model where maybe there was some more chronic changes, and that got me into the area of spinal cord injury, where I went to New York to learn to electrically stimulate spinal cord patients who could then activate their muscle, which they had no control over. And that was sort of the entrance was the liver glucose production and hormonal production. But it got me into more into muscle changes and looking at what's actually happening in muscle, muscle fiber changes, contractility. And for some years, I did some studies within that area and focused more on muscle as such, not necessarily on the metabolism, but more on the structural changes, hypertrophy, atrophy, what happened with stimulation and in different kinds. And then at that time point, I had finished my specialty education and became a chief physician. And then there was a possibility of making a professorship in sports medicine. And that made a big change for me, because then I really went in to all the sports injuries. And that's where, clinically, that was really where my interest was. And therefore, when I looked at the different injuries, and we're going to talk a little bit about muscle, a little bit about tendon, it became very clear to me that a lot of the textbooks on sports injuries were, there were guidelines for what to do, but there were really not many studies behind it. It was very sort of pragmatic approach. Maybe there was a little bit of a clinical study, but no one really dug into what was actually going on in the tissue. And especially when we come to the connective tissue, like tendon, that has been, and I mean, we're coming from almost the same generation, so we remember that at studies at conferences, American College of Sports Medicine, I mean, there was maybe one small section on bone, and that was it. And tendons and ligaments, that was something for biomechanics people, because that was very inert tissue, and there was a tissue that either held or it was broken. And muscle was much more dynamic, and that's where. So I tried to go into the connective tissue, especially tendon, very early, and the real story is that I got an invitation from Physiological Reviews to write about sympathetic control of metabolism, and I wrote back to them and said, I've actually shifted area, and I wanted to write of something else, and they accepted that. And that took me, I think, three quarters of a year to do as a single author, to do a physiological review paper with, I think, 700 references. But it made me dig into the field of connective tissue. And that's where it all started, basically. And then we were going into that. At that time, there was a English researcher who is unfortunately dead today, Michael Rennie, who was interested in protein metabolism. And he was actually sort of discreetly also interested in connective tissue. So when we started trying to find out that there was actually more going on in the connective tissue than we thought, there was some dynamics in the tissue, it's not just an inert tissue, then he became interested. And some of the first studies we did on protein turnover and change of tissue, renewal of collagen, was actually with him. And we stayed long-term friends until he unfortunately passed away. And that was actually the transition. And from then on, I kept my interest in muscle, also in the hormones, but mostly in muscle adaptation with inpatients, bed rest, training, aging, but a very, very vital interest in the connective tissue of tendon. So therefore, it's very interesting that some of my colleagues are actually catching up now on studying the myotendinous junctions, because it all comes together and the things are actually connected in a very nice way, I think. So that's the very short story of how the transition took place. And then it was more accepted in the sports medicine field rather than studying glucose metabolism.
Yeah, it's interesting. I had Abigail Mackey on. She was talking about the musculotendinous junction, and I because I haven't been working in the area, I was sort of still back in the dark ages sort of thing, not realizing there was so much going on, and even the neuromuscular junction and all this stuff that you just think you don't really sort of think about. You just think, the message is just sent across, and so there's a lot going on.
And the story, a quick one. The interesting small story there is actually that some 20 years ago, I was invited over to be a PhD opponent in Ireland at Abigail Mackey's PhD. And that was actually about connective tissue in muscle, because very many people have looked at muscle, but connective tissue was like, at that time,
it's just what you cut through when you do a biopsy.
You want to get rid of it when you have the biopsy.
It's just what you cut through when you do a biopsy.
Exactly. So what happened is that Abigail then came over for a postdoc, and then she stayed on here in Copenhagen, and recently, as you know, became full professor. and is really now looking into the myotendinous junction and also the neuromuscular interaction. So this is really an example that the whole connection between muscle contraction and the connective tissue has a wide range, and in this case, it's been the interface. It's not just two tissues that meet by a coincidence. So I'm very happy for that today that the connective tissue has much more attention than it had earlier.
I wanted to say that was pretty brave of you doing a physiological review on something that you'd only sort of relatively recently moved into, because it reminded me that there's a colleague of mine, I won't say his name in Australia, but he got hassled by his university. They said, you only published like 2 papers last year, but one of them was a physiological review, single author. It's like give me a break. No, that's a huge.
But I mean, it was reviewed, and it was. I mean, for me, it was a check that at least I wasn't completely ignorant in the field, but it was really a steep learning curve, because to going into all the matrix proteins coming from very sort of comfortable words in glucose metabolism, it was a big shift, but the turnover thing and the tissue turnover is still close to my heart, and the methods are about the same. It's just now more protein turnover than it is fat and carbohydrate metabolism.
So that's interesting. So I guess doing that, you would have set yourself up. You could have 20 years of research questions would have come out from doing that review, right? To see, you would have seen how little was known about a lot of areas.
Yeah, but I mean that's of course exactly your point, and I've looked back to that a lot of times, but it's also a big risk, and I remember a lot of especially American colleagues who said that's very stupid of you to going away from a field, because now you've made your name in one field, you can't and that's not been a thing for me. It's more I had an interest, and I don't care, and it could be a blind alley, but I think we've at least moved it a little bit in that area. And I think for the clinicians, it's extremely important. And I mean, it's it's better than me also that there's a lot of hype on translational research, and people want to combine clinic with basic science, but it's not easy. And some people think translational research is just identifying one molecule that could lead to another, but to have truly translational research requires that you get the clinicians to say, hey, there are things going on a more detailed level. And I think, and it also, that there is a tradition here in Denmark that a lot of us who are MDs are involved. Erik Richter is one example. There are several others, Bente Klarlund, who are medical doctors but have stayed in research. And collaborated the whole time with people with other backgrounds, whether it be from exercise physiology, molecular biochemistry, whatever. And I think that is a very, very fruitful thing. And we still have today, my own lab, but also all the other labs here in Copenhagen, have a mixture of people with different backgrounds. And I think that's where the new ideas come up. And I think it's an advantage. Okay.
It's obviously working out, because I mean, it's not a coincidence I'm here, I guess, and it's not a coincidence that I've had, I don't know, 7 or 8 people on that are from Copenhagen. All right, so this is a good background, and just I know let's move on a bit, but it was kind of brave switching areas, because when you go for grants, they obviously want you to have a track record, and so I've got a track record, but not in this. But obviously you did well, so there's a good message there for people. Okay, so why don't we think about muscle? So a lot of people were probably still thinking about, like me, maybe not thinking about the turnover of proteins, and so what's actually going on in muscle? How does it interact with the tendons? So you've obviously got the muscle, the musculotendinous junction, the tendon. How do these things interact, and why do they get injured? So, okay, why don't you start talking about muscle? There's a lot of stuff there, I guess.
Yeah, we can. I mean, basically, I mean, overall, you can say that there are, of course, like in any other case, there are acute things and there are more chronic things. And the acute things clearly would be that you have some kind of rupture. And that rupture could either be that the tendon will tear. Most people know about the Achilles tendon rupture that can happen, or it's what we would call a muscle strain injury, which predominantly happens in the myotendinous junction. But also can happen, of course, further up in the muscle. But it's clear that those are sort of very acute events, and you're not in doubt when you have such an injury with sports, that there is a sudden onset, and even if you're very motivated, you cannot complete your 100-meter race or whatever it is. And then there are the overuse injuries, and those will not attack the muscle. They are predominantly in the tendon and the surrounding of tendon. And overuse injuries has been sort of people have not really realized what's going on. There was a belief for many years that overuse is maybe it's a small partial rupture, like a stress fracture in bone, that maybe it's a small tear and it doesn't heal. But there's more and more signs that that's probably not the case, especially in tendon. And is it a problem? Yeah, it's a major problem, because it's you can say, if you take top athletes, for instance, the by far prominent reason for stopping career, that's overuse injuries. It could be jumper's knee if it's around the knee. It could be the Achilles tendon. It could be in the shoulder. It could be in the elbow. So it's not something you just could put away. And if you're a recreational athlete, it really is an annoying thing. And if I remember a colleague from medical school who said he didn't want to become, musculoskeletal. It's not really interesting. He wants something with neuroscience or cardiology, something real acute things, where it really is life and death. And he said, the other thing is just a small thing. And he phoned me recently, and now he's over 60. So he said, yeah, I have a problem in my knee. I said, you're not dying from it, so it's not a big problem. He said, it's so annoying. It spoils my whole, life quality. And I said, then we better look at it. But it's just to say that I think it's really something that limits people's ability to do something and to find out. And that's really, you can say, the overall theme for why I've gone into this is I want to find out what is really causing it, not necessarily sort of factors that could lead to it, but what is actually going on? What's the pathogenesis of it? What comes first? What comes next? Because preferable, we would like to find a thermometer that could take, that could tell you, I have been running 10K today. I'm a little bit sore. Is it something I should be worried about in my Achilles tendon, or could I run tomorrow? And that's really what we would like to get in that situation. We are getting closer and having more and more science also how to treat it. But if we know what is happening and what the sequence is, then we can also better jump in and say, this is an early stage, this is a warning sign, you should take care of that. So that's the really overall question.
Okay, can I just ask the basics? So like you said, sometimes it's the muscle, sometimes it's the musculotendinous junction, sometimes it's tendon. Do we actually know why? So, I'm a bit self-centered here, but when I run, and we could talk about age later, but just calf injuries, right? And sometimes it feels like it's in a different spot. I go, hang on, I thought it was there, and now it's like over here, and it feels, is that the muscle? Is it musculotendinous junction? And so, do we actually know why? If you want to, you can see me looking down at my calf. Yeah, sorry.
No, we could say.
Do we actually know why? Yeah.
Yeah. I mean, if you take the acute ones, it's clearly a one loading that is too high compared to what it can tolerate, and that could be sort of a special position or something. The overuse is simply also too much load over too long time. Could either be intensity or just the total volume. But we don't know today who's actually registering it down in the muscle or the tendon and say, hey, now we're approaching that we can't do it. But the obvious thing biomechanically is, of course, that you have a muscle that clearly is shortening and you have a tendon that is lengthening. And there is a mismatch because the muscle would like to contract very much, and the tendon is a little bit soft, but it takes some time for it. It has viscoelastic properties. So if you do a contraction very fast, the tendon will appear relatively stiff, and especially if you take the patellar tendon, it's relatively stiff, and that means that you have a part of this unit that really has to withhold or withstand this muscle contraction. Okay. And normally that's a beneficial thing, because you don't want, if you want to jump, you don't want to have it take 3 seconds before you can jump. You want the tendon to be stiff, but you are loading it a lot in that situation. So So why does it happen? Because we do too much compared to what it can tolerate.
Yeah, so even if it's like, so with mine, I used to be a distance runner, so I do a lot, right? But then I'll go, okay, I'm going to try and get back into running and see if my calf goes. I'll run one day, 20 minutes, fine. Next day, three days later, 20 minutes, fine. Next day, 300 meters into it, my calf goes. So, but I guess you would say that's just too much because you've gone from doing nothing to doing like 20 minutes, and then 3 days later, 20 minutes.
You can say that a lot of the exercise we do, especially if they're very explosive and we wanna run very explosive or jump, that is not necessarily a good training for the connective tissue in itself. It might be good for the muscle because you can plyometric training and you want to have these explosive things. But for the connective tissue, it's not necessarily a good training. It's a test of the equipment. It's like taking a small car and trying to drive through Europe with it. It's not necessarily good for the motor, or running a marathon. That in itself is probably not healthy, but it's a test of whether you can do it. So the point here is that there is something that cannot withstand these very many repetitions of explosive things. And in your case, if I don't know how much
just going for an easy jog.
Yeah, but if you have, I mean, it sounds like, especially if it's in the calf, it could very be that you had a smaller muscle strain injury. And of course, then what you do is you will then take some rest and then you'll start again and see how it works. And maybe forgetting that the things will not just heal by itself. I mean, it does, but it just takes much longer time. So when you think you don't have pain and I can start again, there is still a healing process that is by far not completed. And sports people don't want to wait for several years until or for several months before they start again. So that's the other challenge, is of course to say, can we do a measurement saying that now you can be allowed to go for your run as you did before?
Can I just make sure we're clear? Because I thought, hang on a minute, I had to think about that. So make sure people are clear. So all muscles can do is shorten, really. They contract and shorten. So you're saying while the muscle's contracting to shorten, it's pulling on the tendon, so the tendon's stretching. Is that what you're saying?
Yeah.
Yeah, that's just with normal concentric contraction.
Yeah. I mean, if you do, you can take the example, you do an isometric contraction where the muscle, by definition, will shorten a little bit. It's just that your extremity doesn't move, but the tendon will elongate in that situation. And then, of course, there are variations over that theme depending on you do concentric or eccentric contraction, and especially the eccentric contractions, because the load on the muscle will be high. Then the load on the tendon will also be high. And I mean, the eccentric contraction is very classical one. Let's say if you play badminton, for instance, and you put your foot back, and that's the most frequent, at least in Denmark, reason for rupturing your Achilles tendon. You don't get a muscle injury, you rupture your tendon, and that's typically because it's a high load like this.
All right, so just make sure people are clear. So concentric's where the muscle is shortening while it's contracting. Eccentric is contracting, but it's lengthening. Yeah, so like you just showed, if you're not on YouTube, yeah. So if you're doing a bicep curl, when you're lifting it, it's concentric. When you're lowering it and resisting gravity, that's eccentric. And you're saying that's so with badminton, they step back and their calf is contracting while it's actually lengthening, and the Achilles is lengthening. Yeah.
Okay. And then the combination of a little bit higher load, we normally joke and say the most frequent cause for rupturing your Achilles tendon in badminton is 45-year-old, slightly overweight men. So who still in their head play exactly as they did when they were 20. They're becoming a little bit more heavy, and they're not in the shape that they were before. And that's also the explanation why sometimes in running, recreational runners, that they think they can run the same as earlier, but they forget that they're not in the same shape. They might also have put on some kilos compared to earlier. Exactly, and that adding up for many kilometers, of course, plays a role.
That's the thing, because I do these 20-minute runs, and then I think, okay, well, no wonder I'm getting injured, because I'm 20 years older or something, and I'm 10 kilos heavier. And I'm surprised that something's going wrong. Okay, so if we just think again, so I used to think of the muscle as, and you talk about the connective tissue. So you've got the connective tissue throughout the muscle, and then it sort of tapers down and then becomes the tendon. But when I see presentations by Abigail Mackey and things, it doesn't look like that at all. It sort of goes muscle, bang, and then tendon. So is that not
Yeah.
actually what happens? Is that not what a...
That is still, I would say, debatable. And it's definitely so that we can't just see that the tendon goes on and then splits out to the intramuscular connective tissue. But it's probably not either correct that it's just sort of stops and then there starts a whole new thing. So a lot of people in the physiotherapy area, there are a lot of common beliefs that basically it's one long tendon. There's just some muscle fibers in between at some spots. And that's probably not exactly the case. And especially Rick Lieber in the US has done a lot of good studies on looking into this. It's probably a mixture because you have to use the intramuscular connective tissue. Because in contrast, I mean, in muscle, the single muscle cell doesn't go from one end of the muscle to the other. There are longer fibers, there are shorter fibers, but they need the connective tissue between the muscle fibers really to transmit the force. In the tendon, and we've shown that both in the patella and the Achilles tendon, human, that there the fibril, the smallest component or functional component of the tendon, the fibril, actually goes from one end of the tendon to the other. And that means if you've cut half of your tendon, you have half the force. There's no help between these fibrils. They are lumped together in bundles of fascicles, but in essence, they are going from one end to the other. And that's a big difference in this situation. And in the muscle also, the connective tissue has a shifting arrangement. So I think neither we can say that it's just a tendon that goes on, neither can we say that it stops and then there's no more connective tissue, because there is. And Abigail has shown, and you probably talked about that in that podcast, that at the end of the muscle, before it comes to the myotendinous junction, already these muscle cells begin to have different qualities as they go closer to the tendon. And probably the same is the case within the tendon, that there's a big difference of whether the tendon is at the insertion of the bone or it's up there where the muscle starts.
That makes sense. Have you seen Brian Clancy? Is it Clancy? He gave a talk here. He was talking about how muscle fibers even don't just go the whole way along. They split and things. So I guess there's a whole lot going on. And are you saying with tendons that some of them split, or that you're just saying that they go the whole way along?
Yeah, the fibrils, the smallest unit, are going from one end to the other. So that means that there are, and if we talk about overuse injuries in the tendon, and I'm just jumping quickly here, but if we talk about those, there is no good evidence that people have been able in human models to see that there is a discontinuation of these fibrils. So what I'm basically saying is, when you have an overuse injury, and this is not that it happened this afternoon, but something that comes gradually, where you begin to be a little bit sore in your tendons after you begin to have, when you start running, it gets a little bit better, then it comes again, and at the end you have pain all the time. And we cannot, in those situations, we can see changes inside the tendon, but we cannot see a discontinuation of these fibrils. So I think the tendinopathy or the overuse injury in tendon is not so much a rupture or discontinuation, it's rather something that is added on and fills up spaces in there, and therefore the tendon swells and attracts water, and that becomes then sore. So there is a mismatch there in terms of what happens in the tendon and what normally happens in the muscle. And a sore muscle doesn't matter so much. That will go back to normal situation. In muscle, you only have to worry about things that occur like this as an acute thing.
Sorry, just clarify that again.
I'm just saying that if you look at a tendon, you can have an acute injury, which is of course a rupture or a partial rupture, or you have overuse injury where it begins to be more and more sore. It has more and more pain. In the muscle, you have either the acute injury or it's just a little bit overload from training. So if you've been out running and you're a little bit sore in your muscle, you shouldn't take that very serious, because that's more like a soreness, and that is just late onset muscle soreness and will be better.
But you can actually, so back to me, sorry, it's about me, of course. With my calf, I know because it's up high in the head, the head. is sometimes I feel like I'll just be running and I just feel a bit of a tear and then I'm like limping, and sometimes it ends up like black the next couple of days or whatever. So it's been bleeding in there. That
Yeah,
can't be the
yeah.
tendon, right? It's higher up.
No, no, no.
And you're saying don't worry about. Obviously, I have to worry about it, right? But you're saying that won't become a chronic thing. Is that what you're saying? What are you saying
No,
about?
I'm saying that you have probably, as from what I hear, you probably have it started probably with a smaller muscle injury. That would be my guess. But of course, if there is a bleeding, then you are tearing some of the vessels that are inside the muscle. And that is definitely not in the tendon. There is a little bit of blood flow in the
There's not much
tendon, but
blood.
it's very
Yeah,
small.
exactly.
There's not much blood there. So it's probably a recurrent small rupture of a part of your muscle that doesn't have it so good, and there is some scar tissue probably also. Yeah,
exactly, scar tissue. Yeah, so that's the thing, because I wasn't sure. I thought you were saying like if you do an acute muscle injury, don't worry about it. It won't become a chronic thing. It
no,
sure
no, no,
feels
no,
like it
no. This
does.
is not. I wasn't saying that. I was just saying that
Uh-huh.
acute muscle injury is a real injury. If you just have been out running and you feel sore and you have no history of acute
Yeah.
muscle injury, then it's just because you overdid something with a muscle that was maybe not trained enough or not strong enough. So no. You definitely, and this is a very interesting aspect of muscle injury, is that no matter how well you recover, it takes some time for the connective tissue really to recover in the muscle, and there is reason to believe that, like on the skin, if you have a wound on the skin, a traumatic wound, there will be some scar tissue, and
Scar.
there will
Okay.
also be some scar tissue. It's only when it was basically before you were born that the muscle totally heals up and you cannot see there's been anything.
Well,
So there will be some scar tissue in there. It will never go back exactly to the place it was before.
that's what I reckon. Because I was talking about my own calf, but if you were here, you could feel it's like a lump in there. It's like, all right. So if we go back to the tendon, okay. But it's just another thing there. What determines why? So in that situation, why the muscle goes versus the muscular tendinous versus the tendon? Do you know? Is it the forces? Is it because it's concentric, eccentric? Do you know?
That's still a tricky question. It's something with the forces, of course, but it can also be. I mean, if you take the calf, you have this sort of delicate balance between your soleus and your gastrocnemius, the two major muscles there, and they are both contributing to going down into the Achilles tendon. If you look at some of the people who ruptured their Achilles tendon, for instance, the classical small picture of David Beckham rupturing it. It wasn't very a high load. He was just turning, and he was in very good shape. So in some ways, we cannot exactly describe it, but there will be a bigger load on one of the things than on the other, and especially these very quick eccentric stopping movements that will probably hit the tendon very hard. Whereas if you're in a constant activity where there is eccentric contraction also, like jumping or running fast, that will then be the myotendinous junction more. But it's a good point. It's not possible to say exactly where you will have the injury if you get one.
It is weird, isn't it? Because as you said, with David Beckham, it's the same. There's a guy, Justin Marshall. So we just had the Rugby World Cup, and I love I was born in New Zealand, so I was going to be the All Blacks, and they lost. But anyway, classic. He was just running to score a try, So I don't know if you know rugby, but just running. He was just, all day, every day running, and he just suddenly, like 5 meters from the try line, his total Achilles just ruptured. Like nothing. He wasn't changing direction, nothing. So it must be a bit hard. You said you want to get to the point of sticking a thermometer or making some decision.
That's very strange, and I mean I actually saw that one also, and because I was in South Africa recently and followed this World Cup there.
Oh,
So,
let's not talk about that.
no, we won't. But it's clear that there are situations where people probably should not have taken the sprint or should not have run, but we just don't know it. It's a very, very well taken point. We also have some track and field people where you're surprised that it happens in the tendon, where you think, why was that during a warm-up period with things they've done 1,000 times before? So, yeah.
So you mentioned about that thing about how a tendon sometimes can warm up and feel better. Do you know what's going on there? So you'll think, oh yeah, I don't, my Achilles doesn't feel that good or whatever,
Sure,
and then you
sure.
start
Well,
running and
I
it
mean,
feels better.
the research so far, what we have of information is that if we look at the things that occur early in this overuse injury situation, then it looks like that one of the early things that happens is an accumulation of water in the tendon. So it simply swells. Exactly where the water is, we don't know, but what we know is that there are some molecules that are more prominent in that situation. There are some glycosaminoglycans from the proteoglycan complex, but it doesn't matter so much what they are called, but it's substances that have both a hydrophilic but also an osmotic effect, and that means it can attract water. And we've seen some observations in top athletes where they have pain in the Achilles tendon, but it's still not really swollen, not so to the extent that you can see it on ultrasound or feel it or MRI. But you can, with some MRI techniques, see that there is some water accumulation locally. And they're also sore. So the first thing that happens when you are overusing a tendon, Achilles tendon, for instance, is that it's not painful when you run. But if I palpate it, or if you palpate it yourself, you're sore. And you might also have a little bit of morning stiffness, soreness. That's the beginning. And that's probably, and it's not solid proof yet, but it's probably so that is the water accumulating in there. And that's the first thing that happens. And once the water accumulation becomes bigger, the tendon becomes more swollen. And it's like if you injected forcefully water into it, it will also be painful. And that's then painful when you use the tendon. And I think what happens in the early phase is that this water is not very strictly bound. It's maybe sort of more like a swelling thing. So once you warm it up, or at least use the tendon, or it could be stretching exercises, maybe you can squeeze some of that water out in the beginning. The problem is once you've done your run, it will come back again. Or you could also, you could argue that just doing a massage of the tendon could probably help it in the beginning when it's not so severe. Then at the later stage, when you've had it for, let's say, a month or 2 months, then it begins to be some ingrowth of maybe some more vessels, maybe some nerves that are coming in. So that really contains also some pain sensing thing. And then there begins to come a tissue change. So we can see that new formation of collagen, there is a normal formation of collagen constantly, but an excess formation of it doesn't come until 2 to 3 months into to the phase of overuse. So I think the early stage is that you have a little bit of more water accumulation, and then some of the other tissue changes come later on. And it's also, from some of the studies we've done, pretty clear that if you have an overuse injury, for instance, in the Achilles tendon, and you had it for a month, for instance, a shorter period of time, then you are much faster back again than if you had it for 3 to 4 months. And the explanation is most likely that in the early phase, it's reversible water accumulation. And in the later stage, you begin to have some structural changes, and it will take, exactly, and it will take longer time. So if, I mean, it's also sometimes a common myth that you can rupture your tendon because you have pain in it. And there's no sign that this is the case. So it's not that you should be worried that you rupture the tendon just because it's a little painful. But what you can say to people is if you train on with pain in your Achilles tendon, you can do so, but be aware that the longer time you train with it in a painful situation, it will take you longer to come back. And that's important for some people who are in a competitive season. They want to have 2 more matches. You can do so, but be aware that it will take you longer time. And if you train with very painful things, and a lot of basket and volleyball players have constantly pain around the knee because they have jumper's knee, as we call it, the patellar tendon, which is affected. And if they train with that pain for a long time, there's some data that indicate that they will also keep that pain for very, very long time after that.
So to bring it together, so you were saying earlier that basically it sounds like early on when you've got a tendon, a sore tendon, if you biopsy that, you'll find it's just the normal tendon structure. And that tendon structure, even later as you get worse, if you keep training on it and it's sore, that original structure won't change. It's more that you're laying down new things and pain receptors.
Yeah,
and
therefore in the beginning it will be just water, so it will just the distance between the fascicle will just be a little bit bigger, and that can be shown.
Okay.
And then in the later stage, you can say that you have there's some new connective tissue coming in, and that, of course, if you take a biopsy there, it will look a little bit more disturbed, but the main fibers or the fibrils, they are still there. It's just in between those there will be some changes, and that of course can take some time before that can be, let's say, replaced or at least be normalized again.
Sorry, but you're saying within the original core, you have stuff laid down, not just on the outside.
Exactly. No, not just on the outside. And that was also sort of a question that's been around for a long time. Is it only in the outside that things are happening? No, we cannot see any big difference in the dynamics of what's going on in the tendon, whether you're on the surface or you're in the middle of the tendon. And our measurements show that you have a turnover in the tendon, but it's not in the entire tendon. So most likely, and there were several studies showing that most likely you have a dynamic renewal of the tissue while you are growing. And once you're 16, 17, you're basically left with a tendon that you're going to live with the rest of your life. And in that tendon, around maybe 5% of the matrix proteins, which is dominated by collagen, will be turned over, maybe in a circadian fashion. That's what we're trying to prove right now, but there are some indications that you have a homeostatic circadian rhythm where you actually, like when you reuse the classroom and it's dirty and somebody comes and cleans it up and then it looks nice next morning. So there is some kind of, well, not renewal, but sort of a homeostasis of the dynamic part. And those dynamic parts are probably the one where you then accumulate fragments of proteins that then can attract water. And that's the cause for the difference between a normal training. If you then run 10K 2 days in a row, you will accumulate a little bit of water, and that becomes worse and worse. So that's where we are right now in understanding what's going on in the tendon. So it's more dynamic than we thought 20 years ago.
It's interesting because it all fits together as well. So in muscle, you've got muscle turnover, you've got autophagy, you've got mitophagy, and we know that's actually important to be breaking down the mitochondria and turning it over. And if you end up with old bits that aren't removed properly, it causes problems. Same thing in the tendon, yeah? You're saying you want to be turning it over.
Sure. I mean, especially I think a few years ago we looked at and autophagy seems also to be a very important role to keeping this thing going.
Right. Now, blood. We touched on blood flow. There isn't much blood flow at all in tendons. Is that right? So.
Yeah, that's right. But there
they
is
are
some
getting water. Yep.
Yeah, but there are some vessels in the tendon. It's just compared to the muscle, it's much less. And there is also a rise in the flow in the tendon with exercise, and that can be shown. But it's just at a much smaller scale. But the whole idea, and this is really where we don't know enough. In the clinic, we use a ultrasound, and then we have sort of a measurement with Doppler to see whether there is an increased flow in the tendon. But that really just measures that there is more blood in there. So we really don't know whether there are more vessels or it's just the dilation of the vessels that are there. Some animal studies show that with training, you are increasing your stimulation of substances that will make new vessels or new vascularization. But we don't really know what is happening in humans. And the interesting thing is that we use this sign with too much blood flow and hypervascularization as a diagnostic sign for having an overuse. But if you take elite athletes, a lot of them have a lot of blood flow, and you find the same thing, but they never had pain. So there is maybe a correlation, and it's also so that if top athletes have a lot of these changes with a lot of flow, they're more prone to get problems down the road, but a lot of them don't get it. So it's not really a good prognostic sign, because that could have been the thermometer, which you say, okay, if I can see some more blood vessels coming now, you should hold the horses and not run so much. But unfortunately, it could, at this time point, I mean, I don't want to be too definitive, but it looks more like the blood flow is a kind of an innocent bystander, that like you get more vessels when you train. Maybe you also get more vessels in the tendon when you train. And then if you then have an overuse injury and you have fluid coming in, you have some changes in the tissue, then you might form more vessels. But it's not necessarily a good marker for what's wrong.
It's kind of like with the knee and the back. If you scan people's knees and backs, you'll find something. It doesn't mean it's what's causing the pain or whatever. But you're saying, so they have more blood flow, more blood vessels basally, you're saying, just at rest?
Yeah, at rest. And I mean, basically, there's no really good technique so far to see how many vessels there are. I mean, we basically just measure how much blood is coming through. And we're currently looking into that to see whether we can see if it's more vessels when you have tendinopathy. So, yeah.
Okay, so with training, does it depend on if it's endurance or strength? I mean, so with strength training, when people get hypertrophy, do they get a thicker tendon as well as a normal response to the training?
They do so if they've trained for a long time, and probably if they've been training while they were also growing. We've looked at people who do asymmetric sports like fencing or badminton, where you have one leg favorable in front, and you can see that not only is the muscle a little bit thicker on that side, but the tendon is also. But we've tried to train people for 9 months, naive runners, and they didn't get bigger tendons. But if you look at people who are volleyball players, they have thicker tendons than kayak rowers in the Achilles tendon, for instance. So the quick answer is yes, it will adapt to a certain extent. But if you take adult people, there's probably very, very little adaptation in that sense. Okay. But it could still make an adaptation that what we can see that in trained people, there is a little bit of a higher turnover. So the small portion that is actually turning over is actually turning over faster. We don't know exactly how much exercise you need to do, but what we do know is if you put people to bed for 2 weeks or take one leg and immobilize it, you can see that this turnover, circadian turnover, is going totally to zero. So basically, the reason why we don't recommend just rest is that you're pretty sure that everything goes to zero. And it's almost like that you haven't just stopped the car, you've also turned up the engine. So you have sort of to kickstart the whole thing again when you then start. And that's probably one of the reasons why people who just use rest as a treatment, they will then have problems when they start again. Because also all regenerative processes also go slower if you don't do some kind of exercise.
Oh, that's interesting. All right. Now, I know we've been Achilles centric, and I'm going to keep being Achilles centric, unfortunately. So, yeah, the classic thing, I guess, is if you have a calf injury, a sore Achilles. Well, let's talk about it. So sore Achilles tendon, right? Part of you is telling you to rest. And part of you is telling you to keep moving, at least walking. And part of you is thinking, especially since I saw one of your talks a few years ago, is maybe I should train the crap out of it. Because I'll tell you, I got a friend, right? Richard, well, there you go. Richard Sarkis, my mate. Now, he told me years and years ago, he had all these Achilles problems from running, right? And he'd heard someone say that they had an Achilles problem that they wouldn't operate on. They said, operate on my Achilles. They wouldn't operate on it. It's like, and it just kept going for months and months and months, wouldn't go away. Got frustrated and said, okay, you know what I'm going to do? I'm going to do calf raises, really hard calf raises, until my Achilles just ruptures, and then I'll have to go in there and operate on it. Okay. So what he did is he's really hard. You probably heard and really, really hard calf raises, and it didn't rupture. It got better. Right. And then that made sense when I saw your talk, because you said when you've got a chronic Achilles problem, then you actually go in there and cut it, and it's like it fires it up again or something. So just my very, I'm sure you'll give a proper explanation, is that it's become so chronic, it's almost become like normal, and it's not getting fixed. And then if you stress the crap out of it, then you have this infiltration of, and you start to fix it. Yeah. So whether it's sticking a fork in there or.
No, but it's the point here is that you need mechanical loading, and you do it with heavy, slow resistance training, because there you have a loading of the tendon. It's not enough just to do stretching, but you have to do loading of it, but it's controlled loading. It's not the eccentric component. There's no plyometric component where you sort of jump or something. It's a constant sort of a little bit concentric and eccentric, but heavy, slow resistance training. And more recently, we've also shown that even at lower loads, because you said you have to beat the hell out of it, but you can also at lower loads, even at 60%, 50% of what you can lift one time, which is lower than you normally would use for muscle growth, there you can also see an effect. So there's no doubt that this controlled loading of it is a good thing. And I think it's because the turnover rate is going up in that portion of it that can be turned over. And that is probably what is happening there. Whereas what causes the pain and why this person has is all these landing things or in running or jumping. And that in itself doesn't make it go away. So you stimulate something down there that maybe only exercise can stimulate, because we have not found any drug or any injectable things that are equally good to make a quick fix. And I think that's one of the lessons from both muscle injury and also tendon injury, is that it doesn't look like that any pharmacological agent can replace the use of the muscle and tendon. It might be that some of the things can help, but it's not in itself a magic thing.
It's like everything with glucose metabolism, whatever it is, it always ends up generally that exercise is the best thing to do. But so you're saying, though, that this person that's got this chronic, he's a distance runner, he's got this chronic Achilles problem. So my mate Richard had the same thing. He just thought, okay, I'll just do, it feels wrong, but I'll just do really hard. And you're saying you don't have to do really hard, but anyway, calf raises. And, you feel like it's going to make it worse because your Achilles hurts, but it actually gets better. Yeah. But it's nothing to do with firing it up. Because I had this rudimentary thing in my head that because it's so chronic, we're talking about months, years, that it's almost become the new norm, and then you've got to do something different to activate it. Is that just my?
But that could be a point. But I mean, you have another point, is that there is probably some new formation of tissue, not scar-like or whatever we should say, but an excess amount of some matrix proteins in there that fills up. And if you take an MRI or you take an ultrasound, you can see something is not normal there. And the surgical approach would, of course, be, let's remove that. And some people who go through operations get better because you remove something that is in there and you basically then create a new healing. And that can be good, but there is not a good evidence that treatment of tendinopathy with surgery really is the drug of choice. But story-wise or case study-wise, I can tell you that in some tendons where we took tendon biopsy, like you take muscle biopsies, and put in a very small needle to take a little bit of tissue out, some of the people who had problems for a long time, they actually said that after the biopsy, it was better. So maybe we were down there sort of steering up that the whole thing can start all over again. And that might be that in some cases, it's irreversible. You have so much scar tissue down there. So even if you do very nice, heavy, resistance training, you cannot get rid of it. But that's still to be solved. Why this would help? But certainly you shouldn't, just because you have pain in a tendon, if it's an overuse injury, not think that just surgery will help you.
Yeah. So you would say then to people that if you've had a painful Achilles chronically, overuse, that you would suggest doing controlled calf type raises, yeah? And it doesn't have to be really heavy, even 50%, whatever. But you just do a lot of them every day.
Yeah, and then you do a lot of them.
Whatever.
Yeah. Exactly.
How many would you tell people to do? Like 23
times
a day?
The old traditional exercises found first by Alfredsson in Sweden and others, both for patella and for Achilles, they recommended that you did exercises maybe once a day or even twice a day. And we've compared that to just doing 3 times a week, like you would normally do your strength training. And it looks like that 3 times a week is enough. And that would then be, depending on your load, of course, but something like 3 times 10 repetitions, like you would do with your strength training regimen,
really?
would be enough in this situation. We're currently looking into whether even less would do it, because people always ask, how little can I get away with? And we will see how it comes out. So exercises that are not that far away from the way you would do also with strength exercise. So if you go down to 60%, you maybe want to go up to 15, 20 repetitions or something like that. but just 3 times a week would be enough to get the effect over a
That's
12-week period. Yeah.
And that would be enough to get over like a chronic overuse injury.
Yes, there is a 70% effect both in the Achilles and the patella. The one thing that is still not solved, I have to say though, that is the challenge of the Achilles insertional problem. So if your problem in the Achilles tendon is down by the calcaneal bone or down by the heel, it's another story because there can be a lot of other things taking place there. But unfortunately, those are not as frequent as the mid-portion problems in the Achilles tendon. So.
All right. So it sounds like you're saying, because it used to be this thing about, lift yourself up with both feet, calf raise, and then lower with one leg. So it was like focusing on the eccentric. Are you saying that's not really a big thing now? Just up slowly, concentric, down slowly, eccentric. You don't have to be hanging off a step or, whatever.
Sure. But the point was that when it was found way back, it was actually people on a waiting list to have surgery done. And the author also had a problem himself in the Achilles tendon. And then they started doing these eccentric contractions. And there was a period where you were not really a proper person to treat these things if you couldn't say eccentric. And it was sort of a magic word. And the studies I've just referred to you with 3 times a week doing strength training, and those are both for Achilles and for patella, they actually show that it probably is not the eccentric exercise that is the magic thing. You can also get a long way with the concentric. There are people out there who would favor isometric in the early phase when you have problems, simply because it could then sort of squeeze out some of the things and the tendon gets to move a little bit more. I think it probably also plays a role, but I wouldn't be too much fixated on the type of contraction rather than just doing it.
Just do it. Exactly. So we tend to complicate things. So I think just stand there, hold on to the wall, lift yourself up slowly, lift yourself down, lower yourself, and do it 10 times, 3 days a week or something like that. And that you don't have to worry, is it's concentric, eccentric. You're concentric on the way up, eccentric on the way down. And you don't have to worry about sort of messing around. Is that right?
Yeah.
Yep. All right. Now, what about biomechanical? Again, it's Achilles. So what about biomechanics? So obviously, there's a lot of people when you go to the running shop saying you should buy this fancy, shoe and expensive shoe and have reduce your pronation, all these sorts of bits and pieces. Do you have people looked at those sort of things for injuries?
Yeah, we haven't looked at it, but I mean the quick answer here is that yes, there is a correlation between some risk factors if you have a certain way of landing or you have a certain way of your anatomy in the foot, you can show that there is a bigger risk of having it. But there are a lot of people who have some of these risk factors without having problems. So if we find a person that has even if the person pronates a lot or do something and there's not a real problem, then we would not fix it. Whereas the shops that sell you running shoes, they would tell you that you will have problems if you don't get this or that, and the real evidence behind running analysis, I mean taking a video and saying you should have exactly these shoes, is not very solid. So where I would say it plays a role is if somebody has a problem. Then, of course, if we then find that there is something which is very strange, then we would say, let's see if we can fix some of the things. And I think especially the problems with the Achilles tendon insertion, there you really have to look into things like that and how things, and there you can manipulate. But I think probably the producers wouldn't like to hear it, but I think there is an overselling of shoe equipment saying that for you it would be perfect if you did like that. But of course, if a person comes and say, I always have these types of problems, then I would do it. And I remember way back we did some blinded analysis of people who are either patients or elite runners, and we had at least 2 or 3 of the people from the national running team were identified as they should probably have done something because they have a very strange way of putting their foot in the ground. So one should also be a little bit cautious of over-treating. So.
No, exactly. Well, Michael Johnson's a classic. He would lean back when he was running, but he did well enough to win the 400, 800 double, I think it was. So when you've said tendinopathies a few times, it just makes me think of like a disease process. What is a definition of a tendinopathy?
Well, the tendinopathy is that you have pain in relation to the running, that you have a thickening of the tendon, and you have a palpatory soreness when you compress it as a medical doctor, or if you can,
Okay.
sometimes up in the shoulder you can. That's the definition, you can say. And then you can add things on and say you should be able to see something on ultrasound and MRI. But that's
Okay.
basically a definition. We don't take regularly biopsies out just to diagnose what's wrong. Yeah.
Okay. And if someone comes along with a thickened Achilles tendon and things, or if they've done, actually, I want to ask you the treatment again. So you said no sort of medicine or any supplement or anything does anything. The exercise is the best thing. It makes me think a few times it's come up with people where I've said, what about the classic, rest, ice, compression, elevation? What about anti-inflammatories? What about all these things? Do you have any thoughts on those?
The rest and ice and other things is of course has some role, especially compression has a role in acute injuries. You can say with a tendon rupture it doesn't matter so much because you have to find out how you want to fix it anyway. But acute muscle injuries, there of course it has a role, and it has been shown that you probably have a quicker way back if you've done that. But mostly with acute muscle injuries, it's much more important that you start your rehabilitation early. If you just wait 1 week with rehabilitation, it will take you 3 more weeks at the other end to come back. So that's a point. But with the tendinopathy, a lot of these things will not really help a lot. We've looked at the use of anti-inflammatory medication. So despite the fact you can find inflammatory components in there, they're neither in the early phase nor in the chronic phase. People have been able to demonstrate that oral anti-inflammatory medication in regular doses will have any effect whatsoever. Sorry, but there's no role there. You can say glucocorticoid injection as an isolated treatment. One should be very cautious because it doesn't really help in itself. It looks like that there are some tendons where a combination of strength training and not into the tendon but around the tendon with glucocorticoids maybe have an effect. And then there are also some other treatments, platelet-rich plasma, which is used where you centrifuge your own blood and you take the rich plasma there with a lot of thrombocytes, has been shown to have absolutely no effect. It's used, it's given a lot, but it's not having any effect. High volume injection, where you inject saline around the tendon, can have some effect, especially if it's around the tendon, there are problems. And then people have tried with other drugs where they really have not shown very much effect. Shockwave treatment has been used, and shockwave treatment is very good if you have a calcification in the tendon. But if you just have a regular tendinopathy with swelling tendon, you will have no effect. But of course, if you have a shockwave treatment equipment, you are more prone maybe to use it. So
so it's either going to have no effect or maybe some effect, but probably no effect. But if you've got it, you might as well use it.
It's been the shockwave has been shown in the original studies to be very efficient if you have a calcification, and that was from the shoulder. And if you have a calcification where you really can see that there is a calcification area, then it really has the effect that shockwave has and can destroy that. And then there are some laser treatment, etc., others, but it's very, very minor effect that has been shown there.
And you've mentioned collagen. So a lot of people, people always are interested in supplements. You see all over the place, supplements. And generally, if you watch my podcast, I'm generally saying don't take supplements. You generally don't need them. So I know some people go, tendons made of collagen, therefore I should eat collagen. What do you?
Yeah, it's the same discussion as with muscle, where creatine supplementation or with the cartilage with glucosamine supplementation, because the substances are there. Should we then give them? And there is very, very sparse evidence. There are very few observations. I know it's advanced at some stages, and we're actually currently in a study also on elite athletes to look at whether it has an effect. But of course, collagen has to be broken down into the amino acids and then build up again. So you really should have a lack of amino acids in order for me to think it would really be helpful. But it sounds very appealing, and I don't think it. And collagen, I mean, it's an important molecule. It's the most frequent molecule in the human body. So normally we think when we are very muscle oriented, we say, okay, myosin, actin, myosin are very important. And if you're blood interested, you would say hemoglobin, and they are. But collagen is like, it's almost 2% of the entire proteins. So because it's in the skin, it's the glue that holds it together. But I don't see at this point, it's not a thing we would recommend. It's not harmful.
The collagen may get broken down to its amino acids, and then you need to have DNA to RNA to messenger RNA to actually say make more collagen to then put it together. So it doesn't make sense in that regard.
I mean, it's like if I eat a tendon, and it's not so that the fibrils in there will replace the other fibril I have.
Exactly. And people can listen to Stu Phillips' podcast where he says generally most people get enough protein in their diet anyway. Now, what is the best way to prevent tendon injury? So I know you said, so we're talking about doing calf raises and things, or the equivalent for other tendons if you're injured. But is it the same as doing these, 10 reps 3 days a week, whatever? Will that help prevent?
No, not really. I mean, it's very important to be in the shape that your sport will require. And the most frequent cause for having overuse injury of the tendon is, and we know that from people who are very systematic in their approach and write down what they've trained. And the highest risk factor to get it is a dramatic increase in your training amount in the last 2 to 3 months before. And I mean, the mystery is so that if you go out and train and you start running, and we have a lot of people who, weekend warriors, there are a lot of people who want to run a marathon and haven't tried it before, and they then go out and run a lot. And the first 2-3 weeks, as I talked about before, you might get a little bit of swelling in the tendon, but not enough to have pain. So people think it goes well, and they advance with several miles a week. And then all of a sudden they say, why did it happen this week? I just trained the same as I did before. But that's, we can often see with a delay of 3-4 weeks, and then go back and see, okay, something happened there. It could also be that let's say you've been running on soft surface, and all of a sudden it's getting colder, so you run on concrete, and then people say, hey, I did run exactly the same as before. So dramatic changes over time does make a difference. And then, of course, all of us have an upper limit, even if we're well trained, where we cannot tolerate more. And unfortunately, I mean, we don't know exactly if there's any genetics behind it. There are some people suggesting that there are some people who can resist more. But if I have 3 recreational runners and they train a lot, then one of them will come with an overuse injury, and he will say it's not fair because the 2 other ones didn't have it and they run exactly the same. So we all have a higher level, and we know that from elite schools, let's say on volleyball in Norway, where people are together and doing nothing but volleyball. And some of those who actually are performing the best, who can jump the highest, who are in the best shape, they're actually very prone to get it simply because they train too much. And what is too much? Unfortunately, we don't exactly know where it is, but there's no doubt that respecting, and that's what I say to runners, if you feel that you've been running a lot and your Achilles tendon, if you squeeze it and feel that it's more sore than it normally is, then you're on a bad track, and then you should probably reduce it a little bit. Or if you get more sore in the morning when you start the first step, you feel like there is something, then you're also on the wrong track. And then you shouldn't go to 0, but you should reduce it a little bit. And in explosive sports, we can very often have people train exactly the same amount of hours, but they replace a lot of the jumping with this heavy, slow resistance training instead. So a lot of the explosive things, it's probably not the jump that is dangerous, it's the landing of it, which is very hard to the tendon.
Eccentric.
Yeah.
Okay. All right. So you'd suggest if people are in that position, they should not necessarily reduce what they're doing, or just replace some of it with that more controlled sort of calf raises or whatever.
I mean, that would be a suggestion, and that's why the clinical experience is that triathletes are in a very good situation, because if they get a little bit overused by running, for instance, they will just swim a little bit more. Whereas if you tell a very fanatic runner that he should bicycle or row a little more, he would look at you and say, you must be crazy, because it's only running that is fun. So we all have our preferences, but shifting, a lot of the people who can train a lot but don't have injuries is people who do very big variation in what they do. If you do the same thing all the time, and I know from the track and field people, a lot of the elite athletes in track and field have problems when they train too much on the track with spikes. And so there is something where we strengthen the tissue and train or build up, and then there is something where we test whether it can really resist it. And if we test constantly, it's like people say you can't just run a marathon every week. I mean, there are a few people who can, but most people will at some point run into a problem, even if their glycogen is built up again, even if they should be ready, because there's something that doesn't tolerate that you do it that often.
Right. So it all comes to the load and how often and if you're building it up. So things like warming up, stretching. So I had Christian Thorborg. I think you collaborate with him. Is that right?
Sure.
Yeah, he was saying there isn't really good evidence for stretching. Things like that for prevention.
Yeah, no, stretching, and it goes the same here. Stretching is a very good thing to do if you need to be flexible in your sport. So a hurdle runner should do flexibility training because you do get more flexible. You do get a higher range of motion, but we cannot show that it really decreases the amount or the risk for injury. But of course, if you have to perform in a certain way and you have to be flexible, you should do that. If you do strength training, we know that you get less flexible. And that means if you want to do strength training and maintain your flexibility, you should also do that on the top. So that's not really a big issue in telling people they should do strength training there. But for some people, it feels right. And there are a lot of experiments where they've put warming up on people who normally didn't warm up, and it didn't influence their amount of injuries. On the contrary, but people who normally do warm up, if you took the warm-up away from them, they reported that they felt they had more injuries. So it might be also sort of what you normally do, and it's sort of a ritual you have to go through. But then, of course, the warm-up instead of stretching, but the warm-up has, of course, we know that for performance, it has an obvious role, that your muscle, the temperature, the contractility will go up. So if you do a 100-meter run, I would suggest to warm up, but the injury you get is not necessarily from whether you warmed up or not.
Yeah, okay, that makes sense. I remember there was a distance runner, Robert De Castello. He was a great distance runner for Australia in the 80s. And I remember he was saying he couldn't even get within like 2 feet, so 60 centimeters of touching his toes. But he didn't care. He didn't do, he said, what do I care? I'm a distance runner. I'm just moving through this small range. So as you say, if you don't actually need that range, then you don't need to try and get that range, right?
But there is,
all right. So,
there is something about the connective tissue and the explosive things which is very puzzling, because now you mention a famous runner. We have a famous Danish track and field person who back in the 70s won the European championship in high jump, and he was a very good decathlon, very explosive. He became a doctor later on, and he told that, because he was giving an interview, he said that even at the age of 50, he almost had the VO2 max, his endurance capacity as before. He could almost lift the same weights as he could before, but if he went on the track field with spikes on and did a 100-meter fast run, he would get an injury. So the explosive things he had to avoid.
This has been great. I know you need to finish up soon. So how about we go to some of these Twitter questions? So Fabian, can a fully torn, this sounds a bit personal, I think, for Fabian, can a fully torn proximal hamstring tendon heal back to the bone? If so, what is the cellular mechanism? If so, is there anything a patient can do to make the formation of a neo-torn tendon more possible?
Yeah, if you have a muscle injury in the back and it's at the myotendinous junction, it will not require surgery. But the example that he mentions, a totally torn off tendon, will actually require surgery, and I don't think that should be left unoperated, because it will not by itself grow back at that stage.
Okay. So it doesn't just sort of attach to the, I don't know, other bits and pieces. It ends up just
It
blowing in the wind.
does, but it does attach in some way, but it's not going to be as it was before, and the ability to do sports will be limited.
Okay, just the thing about age. So with age, we talk about, the person you mentioned getting injured more often and whatever. What actually happens with age? I don't know if you said it earlier. Is there less turnover with?
It doesn't change very much, and actually, a lot of the changes with getting a little bit stiffer tendons with age is more related to not doing exercise than anything else. If we take people who are very good shape when they're older, there's not a big difference on the tendon. Whether it really is reduced in its tolerance before it breaks, we really haven't been able to measure that much in humans, but maybe there is a little bit of reduction. But on the other hand, the muscles also get less strong. So it should go along with each other. And old people are not very prone to get tendon ruptures, for instance. And then you can say it's because they don't do exercise. But even those who do very much exercise, master athletes, they're prone a little bit to get the muscle injuries. But because they still do a lot of explosive, but it's not very prominent that they get the tendon ruptures. So
they don't get changes like, you tend to lose elastin and things like that. So I guess, but you're saying the tendon's mainly collagen. There isn't much elastic in there, is that right?
No, there is a little bit in there, and it looks like that your tendon can adapt a little bit better when you use it, and if you don't use it, it tends to become a little bit stiffer, and that happens with age rather than because you don't do so much exercise.
The lack of activity.
Like the loss of muscle. Yeah.
Okay. So I had Windarabe on here, and he was saying he's got some evidence that people with more type 2 muscle fibers get more injuries. Now, does that make sense? I guess that makes sense. Yeah, it's just putting more strain or faster strain or something on the tendon.
It's probably the fast movements there, because the tendon has this viscoelastic properties. So the faster you make a movement in the muscle, the less elasticity you will see in the tendon, because when it goes very fast, if it's viscoelastic, it will take some time before it elongates. So the more fast fibers you have, the more explosive you are, but maybe also the higher risk. And this is a very interesting sort of dilemma, that actually the things that make you perform very well is actually also some of the things that make you go in a higher risk for injuries. Like a karate kicker, if you're very good in relaxing your backside of your hamstrings, for instance, so you can kick better, so you don't get a co-contraction of the antagonist muscle, you're also in a higher risk of getting injuries in the knee. So the more you train just to let the muscles activate for performance, the more you also activate maybe you inhibit some of the muscles that are actually protective for the knee, for other things. So I think there is a paradigm in between this or a dilemma between performance and the risk of getting injury.
Okay, Mark here has a question. To what degree can the structural changes in tendons seen in people with diabetes be reversed with resistance training, and can the risk of tendinopathies be normalized? Is that a thing? Wasn't aware of that.
Yeah, they have a higher risk for tendon rupture, and there are a lot of things that are not solved with the risk for tendon rupture and for tendinopathy. There are also certain drugs, antibiotics, the fluoroquinolones, where it's reported that people get tendinopathy when they get those, and there are a lot of things that we still don't have an answer on yet why this is so. But diabetic people have a greater tendency to get tendon problems, yes, and we think that they have the same effect of doing strength training, but we are not pretty sure there. I see my battery is almost running out on my phone, so yeah.
Okay. All right, so we're going to finish up soon. If you don't mind, where do you see the next big scientific or clinical breakthrough in tendon research, clinical practice, and in what populations, athletes, metabolic or rheumatological diseases?
Yeah, I think the elite athletes, they will just train more when we tell them how to do it optimally. I think the biggest advance will be in the recreational athletes or people who do recreational sports, because we will be more able to tell them what signals and what findings they should be worried about, and where they, by just small adjustments in the training, can actually continue doing most of it. And that's what I strongly believe we can come to, and I think we're getting there very soon.
Okay. So also, Mark, again, since there are adipokines, so these are proteins released from adipose tissue, so fat. Myokines are released from muscle. Hepatokines from liver, just so the audience, etc. Do tendons also secrete molecules during exercise? Tendokines, he's calling them.
The quick question is, we don't know. There are much less cells in the tendon than there are in muscle, and it's also difficult to say whether a substance in the tendon should go abroad or to some other tissue to do something. But locally, you can say that what we do know is that there are in tendon cells, and that's published just last year in this circadian control thing, that the individual cells in the tendon release extracellular vesicles like they do in other tissues. And those vesicles are signaling between the cells in the tendon, and they are under circadian control. So it's actually so that there is a proof that there is a lot under circadian control. And that's probably very important, because that tells the rest of the tendon what is actually going on. We also know that when we measured with microdialysis some years ago, that, for instance, IL-6, interleukin 6, that is known to be released from muscle, is released to an enormous amount from the tendon. But what that means, because it's a high amount, but in the total sum, it's very little, because the tendons are very small. But if that has a role locally, we don't know. But it's a very tempting idea. Thanks for the suggestion. Yeah.
So with circadian changes, so if you got messed up by jet lag or whatever, it could potentially be affecting your tendon, or it's a bit early to say that.
That is exactly what we're looking more into now. And maybe also the question, is it better to train in the morning than in the evening, and what, things like that. But it's really difficult to make observation, because you would think that people who have night shifts would have more injuries. But then again, they adjust their training when you do that. But it's a very good point.
That's interesting, because I know I heard a talk by a sleep researcher, Matthew Walker, I think it is. He was talking about if you don't sleep enough, then you don't get amyloid, that's associated with Alzheimer's, removed, because while you're sleeping, it's removed so it can build up. So it might be the same with tendon, where you're getting that turnover. If you're not sleeping enough, or your circadian rhythm's messed up.
And the other point is that we know that growth hormone and IGF-1 are very strong stimulators of the connective tissue. And I mean, even if you have an activation of those with exercise, the strongest activator of growth hormone is sleep. So that's really where you probably have a lot of the regenerative things. The growth hormone is by far the highest during night, and that's a very strong stimulator of formation of collagen. So that could be another issue. Yeah.
How about if we, just before your phone dies, can you just give a quick takeaway messages if possible? So what do you want people to take away from this unless your phone dies?
Sure. I think that the important point here is that sports injuries is an overuse of the tissue, and that the connective tissue that we normally just feel as very inert and passive structures is more dynamic than we think. That constant exercise is really good for you. It's about finding the balance between doing the exercise that is really stimulating the tissue and not misusing it. And that balance, we try to be better and better in trying to give good advices of how much is good and how much is too much.
Right. Thank you very much. So as usual, exercise is good for us. And even if you're having problems, and if it's your tendon, for example, it's still good to keep moving it. And maybe just don't overdo it. So, everything in moderation. Okay. Well, thank you very much, Michael. Thanks for coming.
Good. Thanks, man.
Okay.
Thanks.
Bye-bye. See you. I hope you enjoyed this podcast. Please like, subscribe, pass it on to your friends and colleagues. Check out the other podcasts. Thanks again.